Welcome to Dr. Jeffrey Roth's Looking Good and Feeling Great podcast, live from Las Vegas, with his co-host, Darrell Craig Harris.
Hi folks, it's Dr. Jeffrey Roth here, your board-certified plastic surgeon in Las Vegas, Nevada, and we are at it again. Who'd have thunk it?
Yes, we are, and it's heating up in Las Vegas too.
It certainly is. I think we usually get about 2 weeks of really nice springtime weather, and then it's hot. And it's been back and forth a little bit. It's a bit bipolar, but now I think it's this weekend. It's here to stay. The triple digits are here to stay.
Time to bust out the sunscreen. You just happen to have a sunscreen.
I just happen to have a sunscreen, and it's really great sunscreen. So
hence the name.
Hence the name. Really great sunscreen. Yeah, you can't say stuff like the best or something, but you can say it's really great. So that's what we went with. So if you are in the market for a sunscreen, and you should be, it's really great. It took us 17 years to figure it out, and it's a shameless plug. It's a sunscreen that is mineral based, not chemical based, and so it acts like a shield, and it bounces the bad rays away from you. And we have facial and body. We have tinted and non-tinted. And the gals at the pool, they love the tinted facial sunscreen because they don't have to wear makeup, so they really dig that. And then I put it on my daughter and as well, and even the folks that get laser resurfacing, they use it because it doesn't sting. So everybody should wear sunscreen, and they should reapply it, especially if you're in a sunny place like Las Vegas. So do ring us up, and we can make that happen for you.
Yeah, we have available on our website, jjrothmd.com. So you actually just were at a very awesome symposium up at UCSF, right?
I was. So at UCSF, the University of California, San Francisco, which is just a phenomenal place. 22 years ago, more than that, a little more than that. 20 years ago, I graduated, I guess, the UCSF Plastic Surgery program. They made a mistake and let me in. And the training was just phenomenal, and it continues to this day. And I tell the residents that are there, I said, at some point, you're going to graduate the program. I know it sounds like forever. You're going to graduate the program, and you're going to be in the operating room by yourself, and probably it'll be in the middle of the night. And there's this moment that they call white tile syndrome. And what that is basically you get to a point in the operation, and there may be a little bit of a wiggle in the road, and it wasn't exactly like you planned, because people can sometimes do that for you. And you're going to look behind you to see if anybody's there to help you out. And there ain't nobody there but white tile.
Nobody to save you.
So I told them, I said, look, you're getting terrific training by all these really great guys and gals and professors there. So what I would do is I would say, okay, so what would Dr. Mathias do? What would Dr. Hoffmann do? What would Dr. Asher do? What would Dr. Rosenfeld do? And I'm like, okay, I'll do that. So I said, it's really easy. All you have to do is emulate the training that you had, and then you'll be fine. And so UCSF plastic surgery, again, 20 plus years ago, I was there. And so every 2 years, they have a symposium, and the alumni get together, and they have a big dinner for their graduating residents that are going on to either private practice or academic practice or more fellowship, et cetera. And it's really a wonderful thing. And as much as you see folks that you haven't seen for a long time, which is really, really nice, you also get to see what's going on in the research lab, which is really terrific. And then also people like to present their work, and UCSF, it can be everything from reconstructive and microsurgery and hand surgery and gender reassignment surgery to social aspects of surgery and community health, et cetera. So it's really, really interesting. And you sit there during some of these lectures, and I myself am in awe of technology and the things that we can really do now. From a microsurgery standpoint, where you take tissue from one area of the body and you go to another area of the body with it, especially the microsurgery, which are free flaps, where you actually take tissue based on an artery and a vein, and you plug it into another artery and vein at a recipient site to cover the soft tissue. It may be a big soft tissue injury from a trauma or from cancer, whatever the case may be, but you need soft tissue coverage. And so these folks are moving more and more muscle and tissue and soft tissue on smaller and smaller arteries and veins and really opening up the possibilities. The other things they do are nerve reanimation, where they can go ahead and plug into dormant nerves with nerve grafts and make the nerves work again. It's just absolutely phenomenal what these folks are doing. So that was the microsurgery, general reconstruction of it. Also, there was the breast portion, which was really interesting, not only because people are really, really looking at this stuff. As you know, 1 in 8 women are going to have breast cancer at some point during their lifetime, and then more may be diagnosed for biopsies, et cetera, et cetera. So the whole idea was, okay, we've gone from, okay, let's go ahead and separate the patient from the disease and just make a big shark bite and take out all these nodes, to, okay, how can we spare tissue? And so how can we leave skin? How can we leave the nipple intact? How can we, and then make it look nice afterwards? And so now they're talking down that road, which again, they're really pushing the boundaries that we have. And the technology's gotten better too. There's this stuff called acellular dermal matrix, which we can put between the pectoralis major muscle, and then you put, an implant there, and then you put this ADM there, and then you have the skin on top of it, which again, if you asked me this question 15 years ago, could you do that for breast reconstruction? That would be an automatic fail on the boards. No chance. But now the technology has gotten so good, and the techniques also have gotten so good, that you're able to go ahead and pull this off.
Right.
So that was exciting. San Francisco being San Francisco, there was a thing on transgender surgery, and that was really pioneered at Stanford, which is our kind of cross-peninsula rival, although we have a lot of conferences together, and they're very, very smart, and they do really good work down there as well. And not only just the, how do you change from one side to the other side, the criteria that you have to go through, whether it's the St. Louis criteria, et cetera, then, okay, let's physically change sides, and how do you do that operatively? So they went ahead and talked a bit about that. And then they also talked from an aesthetic standpoint of facial surgery, facial feminization, for example. And Dr. Doug Osterhout, who was really a pioneer of this in San Francisco for forever, he recently retired. And so there was the chief now, Dr. William Hoffmann, who really is a craniofacial, he's a plastic surgery expert, but really craniofacial. And so he's kind of stepped in and has done more and more of that stuff at UCSF as well. And basically the planning behind it and what makes a male versus a female from a facial standpoint. So it was really, really fascinating.
Yeah, I think, it's amazing. That the technology, of course, is always changing, I'm sure. And that's part of the reason why you guys do get together and to share information. How important do you think that really is in terms of just helping everybody and helping the practice move forward?
It's absolutely critical. And that's why we go to meetings and we sit through lectures. And then, again, you and I have talked about this. My favorite part of most of the big national and international meetings is lunch. And the reason why is not the very nice box lunch that they give you, and usually there's a cookie involved, but it's a chicken sandwich. And that's gotten a lot better over the years too, by the way. So, but
technology,
the technology, yeah, right. They can make everything taste like chicken. But lunch, usually you have, a guy from Vegas, me, and then you have a guy from Rio, you may have a guy from Miami, you have a guy from New York, you may have a guy from LA, and then we talk about the lectures that day. And one guy will say, oh, I think this is great. And the other guy says, no, it's terrible. I'll tell you why. Or I think that was great. Nope, it's not. And, I used to be his fellow, and I'll tell you that he doesn't do that anymore. Right. And so you cut through all of the stuff and you get down to what can really help your patient. And if you can take one, I've told the young guys and gals this, you can take 1 or 2 pearls away from a lecture or a symposium or whatever, then absolutely completely worth the trip. And if you can apply it to your patients and your practice, yeah, absolutely.
Right. And there's different, we talked about that before, but different regions have slightly different approaches to different topics, right?
Or guys from out of the country, or just a different way of looking at things. The other thing that I've been seeing, which is refreshing, and especially at this particular conference, there's also the Indy conference, which Dr. Rosenfeld runs, which is terrific, is the guys that get up there and are absolutely brutally honest, meaning you have your Dr. Val Lambros is done that. He'll call the BS out. And one a guy who was up there, Ning Chang, who's great. He really delved into his own case studies and showed some fantastic results, and he showed you some results that made a left turn. And that's okay, because that's where you learn.
That's right.
And this is what I learned. And, these are the things that I won't do again. And this is why 10 years later, I'm doing this operation differently, et cetera. And so guys like me in the audience don't have to have that learning curve and went, oh my gosh, this is a guy who's done, a bazillion of these,
yeah, well respected.
Right. And he says he's still trying to figure it out. And this is where I came from. This is my evolution. This is what I'm doing now. So that's worth its weight in gold, and so that for me is important to really kind of sniff out, is this guy, just going ahead and being puffery and showing his great results, versus is this a guy that's really, or gal, that has really thought about and took a look at his own series. And that's brutal when you do that sometimes.
Right. And self-reflection is it's tough. Challenge, right?
It's tough. And that's also what we have here in Las Vegas and around the world and all the teaching hospitals. They have what's called a morbidity and mortality conference, which is, especially on general surgery, is you basically get up and tell about the mess ups from last week. Right. And at a major teaching hospital, that can be, a few of them, right? 1%, but you do.
But that's crucial.
Yeah. But it's crucial. You don't, the old adage is you don't learn anything from a great case. Hey, I had this case, it went great. Who cares? But, I had this case and this happened and this happened and this happened and this is how I fixed it. So that's where you learn, and you learn not only to fix it, but to recognize, oh, hey, I know the ending of this movie, and let's not do this. Or even more important is to say, okay, that's something I'm not going to do in my practice, or to prevent it, or sniff it out even before you get to the operating room. Right. So that was interesting. So you had that. You had hand surgery, which was also really sort of interesting, as what the technology with hand and hand rehabilitation and everything else like that is just spectacular.
Yeah,
what to do.
And it's also UCSF. They have unique challenges because of being in San Francisco and all that they deal with there. The city has some challenges, as we probably have all heard, with the homeless population and different things. So what is the unique thing that they really deal with more than maybe some other hospitals?
Sure. Well, again, it's
several things.
It's a quaternary referral center. So they get referred stuff from everywhere. And while I was there, there's oftentimes people would have failed surgery elsewhere, and they would come and we would try our best to figure it out and make it better, et cetera. And often we do. And just because they're surrounded by such really good, smart people. So even if you have to call on your cardiology friend or your anesthesia friend or whatever, they're all really just so darn good up there. And it makes everything work. Again, it's really kind of an interesting place. Now, the city itself is still very much a beautiful city and all that. And it's going through its challenges, especially as you mentioned with the homeless population, where we saw a interaction with that, especially at San Francisco General. Actually, it's Zuckerberg's San Francisco General Hospital now.
Oh,
so
interesting.
Yeah. And so thank goodness he gave a lot of money, and that really has helped out a lot. And so they shouldn't stick his name on there. That's legit, I think. But in any case, so at the General, we've been taking care of in sick patients with no money, et cetera, forever. And so in that particular patient population, especially there, because in that district, there's lots of drug abuse, et cetera, et cetera. And some of these folks have had this for a long, long time. And so there are certain things that you see there, and you see in every city, in every metropolitan city, but it's concentrated there because that's kind of where they know to go. The IV drug abuse population, sometimes they won't have clean needles anymore, but moreover, they run out of veins, right? So they've hit every vein. And so what they'll do is they'll just inject their drug into the soft tissue. So what happens there sometimes is you'll get a soft tissue infection, which can sometimes lead to abscess, which then, needs to get drained, et cetera, et cetera. So what they've done is they've continued to rethink, okay, how are we serving this population, et cetera, meaning it used to be a big deal and you'd have to get admitted and you have to wait a couple of days because there was never a room on the schedule. And then they went ahead and made this thing called Oasis Clinic, where you would come in, you would make an appointment, you would come in, you would get addressed, and then you would, be able to go home depending on the severity. And so that fit in better with the patient population, because what they were discussing actually this last symposium is the patient population, if they wake up in the morning and basically the main two goals are, okay, how am I going to eat today? How am I going to get the drugs today? Because that's kind of where you are.
Yeah, they're in that zone.
Right.
Yeah.
So that's the thing. Now, so meaning that they're not going to, run to the doctor fast because something really has to be big to push them out of that. Meaning this thing really on the arm really has to be big and red and pussed out and swollen for them to go and seek medical care. So now you seek medical care. Now you go into the hospital and things get washed up and IV antibiotics and all that kind of stuff. So now you go to a place that's very structured that, breakfast comes at 7, lunch comes at noon, dinner comes at 6, et cetera, et cetera. And then you go from there to back on the street, which is very unstructured.
Exactly.
And
right.
so they did this whole series, it was really interesting, of interviews with all sorts of stakeholders, whether it's the doctors, the nurses taking care of them, the patients themselves, et cetera. And what are the barriers? And so one of them is kind of, okay, well, what's going on in the street? Meaning the doc and the nurse when on discharge will say, okay, we'll wash it 3 times a day. Well, if you don't have access to clean water, that may not happen. And so lots of these folks, are on this wheel of coming back to the ER because they couldn't take care of it for whatever reason and they got worse and blah, blah, blah. So there was a whole study of that, of kind of barriers to care and to try to have people not be on that wheel.
Right, to kind of break them into a healthier situation. But, but there's so many challenges with
so many,
as we know.
The housing itself challenges, there's the mental illness challenge, there's the drug addiction challenge, it's just a ton of it. And then how do you interact with the medical community in such a way that they understand what's going on, and then it behooves them to come back and get care. So that was a whole study in of itself. The other interesting study, which was medical, but not medical like in the OR, is in children with craniosynostosis. Okay, so craniosynostosis is where you're born and the bones of your head are oddly shaped, or they don't line up correctly, or the sutures, the areas between them, there's something wrong with them. So anyways, it's the kids that often have kind of misshapen head, et cetera, et cetera. Okay. And UCSF has always been spectacular at that. It's something they really, really do. Now, as you can imagine, when you're younger, meaning, the 1, 2, 3 months of age, things are much more pliable, et cetera.
Right. Because you're still forming fully. Right.
Exactly. Yeah. So as you get older, things are less pliable and it's kind of a bigger deal, et cetera. So they went through, the records and said, okay, who's showing up late? Why are they not showing up, et cetera? And a lot of that is didn't know that there was a craniofacial clinic, who's actually referring, when are they first getting seen by a doctor, and then when are they first actually going to the craniofacial clinic? And they found obviously disparities between race and between socioeconomic and et cetera, right? As always. Yeah. And so they're trying to figure out, okay, how do we get those kids into the system sooner so that they can have a less operation and better outcomes? Right. Yeah. And so then again, they took a systems approach to medicine. And so they're putting those things into place to try to get the word out, trying to get these kids in the medical system faster so they can go to the OR if they need to go to the OR and, have better outcomes with less surgery. So that was also, I thought, fascinating up there, which UC does well. And again, most of the major centers do that too, the public outreach, public health, et cetera, but they've already prided themselves on that.
For doctors dealing with, because that's a pretty intense situation, dealing with homeless, dealing with those socioeconomic issues as well, being in medicine. How does that affect doctors psychologically? Is that really challenging? I would assume it would be for them because they kind of know they're doing their best, but they don't know what the outcome's going to be for the patient.
Well, yeah, there's the medicine part, which is what you're trained for. And, there's an abscess. We're taking the operating room. We wash it out. We'll put a wick in it and then put them on antibiotics. But then, okay, that's great. But there's a whole nother part to this that if you really want the patient to get better, you're going to have to deal with. And so most people find is if you have a team approach, meaning you have social workers and you have nurses and you have folks like, okay, well, let's go ahead and get you set up. They have these hotels in San Francisco for that sort of thing. Okay, let's go ahead and get you for, a voucher for a week or whatever it is.
Just to get them stable.
Right. Is there a way, to do that and actually talk to them and figure out what else is going on in their universe, which may be an impediment. And then sometimes, even as a doc, you get semi-street smart, again, depending on where you trained and what they tell you. The other thing to do is, like anything else in medicine, listen. Listen to your patient. Okay, that's great, doc, but I don't have money to get the antibiotics. I have a bum leg. I can't walk, more than a block at a time. How do I get to a Walgreens? Right. So there all these little things that you've done the medicine, you've made the right diagnosis, you've done the right procedure, you give them the right antibiotic, but guess what? Their treatment doc may fail because they may not be able to be compliant with it, not because they don't think it's the right thing.
Their circumstance,
it's
or
whatever. What's in their circumstance, what's going on in their.
That's got to be so
universe.
Challenging as a medical professional. I mean, I guess even under normal circumstances, but particularly not.
So you do stuff like, I remember this is more than 20 years ago. I remember this guy, and I was there with my attending, and who had been at the county for a long, long time, and he says, look, I know, you don't have stable housing. This guy, big jaw fracture, et cetera. So you're supposed to swish and spit 3 times a day. Okay, well, now how's this guy going to go get to the saline? Yeah. So my attending actually told him, he says, if I was you, I would go to McDonald's, Burger King, whatever like that, right? And go get yourself, a cup of water, and there's always some salt packs laying around. He's like, go get a couple of those, go get some water, go out to the curb, okay, and put the salt in the water, swish, 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 and spit it in the gutter. It is what it is. And guess what? If you have a little forward thinking about that guy's particular circumstance, he's more apt to actually kind of do the program, as opposed to, okay, well, here's your prescription, sir. I'll see it.
Of course, ultimately, no matter the circumstance, you want the best for the patient.
Right. And you talk to these guys and gals and you feel for them and hopefully you are empathetic when you are in medicine, and you do try, not only to get the diagnosis and procedure right, but actually fix the patient.
That's why you're trained to do. That's the whole goal, right? Of course.
So yeah. So, and there's some places better, you get more exposure to that, than not. So yeah, at UC we're very fortunate because you get the county and that patient population, and then you get UC, which is all sorts of people coming in there. It just it's that part of it was really fun.
What's your I'm kind of changing topics a bit, but your thought on when you meet with patients and they're not completely truthful with you?
Oh no, that happens.
That's kind of a big subject, I know.
That happens all the time, and I was just talking actually to somebody about this. We tell the patients, like, okay, 2 guys you can't lie to. Your surgeon and your priest, okay? Everybody, boyfriend,
girlfriends, whatever.
Husband. But 2 guys you really, really, really got to tell the truth to, because it's not going to go any further. Yeah, and it's important. We were just talking about this, and this was back in Philadelphia, the trauma days. And so this guy came in. I forget exactly what the issue was, but we had to go ahead and operate on his arm. And of course, you go through, have you taken any medicines, any drugs, blah, 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 everything else like that. No. Anyway, we took an x-ray, and this guy actually had old broken IV needles in his arm. Okay, now that's okay, except for the fact that my attending, you're going to open up the arm, you're going to look for stuff, and you're going to run your finger all the way through that. Right? And so he would have nailed his finger. So we said, hey, look, you really, really, really got to tell us. And he's like, nope. I'm like, okay. And so then we put the x-ray up and we went, okay, what's this? Well, 20 years ago, et cetera, et cetera. Like, that's okay.
You just as long as we know what's coming.
You gotta tell us, you know what I mean? What's really going on here? Mm-hmm. And that can make all the difference in the world, because what you don't like, and you can ask my wife about this, is you hate surprises, right?
Right. Yeah. In the OR, that's not a good thing.
Especially surprises, oh, by the ways and surprises. Yeah. And even to the point, and again, this is back at UCSF, again, 20 plus years ago, is you're in there and you're doing this case and blah, 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 and they're bleeding, but they're not bleeding from like a vessel, right? They're kind of got this ooze that's kind of going on. You're like, gosh, they're oozing from everywhere. And so now there's some medical things that can cause that. You're thinking, oh my gosh, or is his platelets all shot? Is it FDIC? Am I going to have to get hematology involved and give them more medicine? So typically you can get it through and you get done with your surgery and then you wake them up and go, hey, you were kind of oozing and stuff like that. Did you take any medicines? Did you take any? And that's when I learned about herbal supplementation because again, it's Northern California. And so, I ate a bushel of St. John's wort yesterday. And you're like, oh, good Lord. So the other thing with UCSF, which was interesting, is one third of the town was Asian. And so many of them went to their traditional
herbal medicine
physicians down in Chinatown or the other towns. And they've been doing that for thousands of years, right? And so some of those medicines, yes, absolutely have an effect on the bleeding system or respiratory system or whatever the case may be, and may interact with Western medicine, whether it's drugs or therapies or whatever. So that's when I learned to okay, you got to take an herbal history. You got to take a vitamin history.
And sometimes they may not want to actually fess up oh yeah, I'm taking this, but I know you may not agree with this approach.
And you really, you got to just go. They says you have to tell, you really, at that point, it's a no judgment zone. You know what I mean? It's okay, well, what do you got? Okay, let's handle it. Yeah. You know what I mean?
Or maybe you get them off of that for a month or 2 months and then whatever.
Figure that out later. But and because people tell you, I'm done, I quit smoking, 6 months ago.
We've had that topic.
And you walk in and they smell like a chimney. And you're just like, oh, good Lord.
Yeah, so, they don't understand how that's going to affect surgery and blood and
all of that sort of thing. So we hope that you build trust between you and the patient. Sometimes it's very hard when you're in a big clinic and you're seeing like the hand clinic, you see 200 hands a day, up there, whatever the case may be. But you try, and you try to really get down to the person-to-person sort of level. I mean, sure, I had a whole bunch of education and training and all that stuff. But hey, there's places where I don't have a knowledge base, and I have to trust the plumber. Right. I don't know much about plumbing and
the university professors in that scenario, is that a big topic for them? Like, hey, you've got to really talk with your patients and got to have, I would assume it would be. But
I think if you asked that question 40 years ago, probably less so, there was kind of a more patriarchal top down, such. But I think that we've learned, or at least I hope to over the years, that if you listen to the patient will tell you the diagnosis. And in the internal medicine guys and gals will tell you that 80% of internal medicine is the history. So if you do a good history and you figure it out, usually tell you what it is.
Right. And listening. Right. Is so important.
And then by you listening, they're more apt to tell you, stuff, and then listen to you when you say, okay, you really, really have to cut this out, and this is why. Not just cut it out because I'm the white coat and I said so.
Exactly.
Well, yeah, that you can get away with that just so much.
It doesn't work as well today.
But if you get but if you get the why, the reason why you can't smoke for a facelift, breast lift, or tummy tuck is it will fall apart.
Right. And you're spending all this money.
Right. And because it's on tension, and tension's going to be, what do you think it's a vasoconstrictor, et cetera. Then they start okay, well, if you give them the why, and we talked about that at the last UCSF meeting. If you give the why, it actually will stick and make more sense.
Yeah. And I mean, I've been to some consultations with you. And that's something I've really enjoyed is that you really take your time. You ask a lot of questions. You're not in a hurry, as unfortunately many doctors today see so many patients.
Right. So I'm not efficient. You get the consultant, you're like, you're really not efficient. Yeah, I know. So,
the care of the patients, the bottom line.
I keep telling myself that. So like a mantra.
I keep telling my office
like a mantra. Yeah. So my office manager with a stopwatch. So I'm kidding. So no, but we've had that, kind of discussion of, okay, how can we make that balance of, not just myself, but, everywhere they try to make that balance of really taking care of the patient, listening and going through things well, and still, being efficient. So some of the efficiencies, are outside the consult room, and can we fix that, make that better so people aren't waiting in the waiting room? It gets me crazy.
You do a great job with that and waiting around. I think you definitely, you guys are very organized with that. And I think you do a great job.
Yeah. It gets me bananas. And the other nice thing about the UCSF conference is there was the aesthetic surgery part of it. And again, people went ahead and put up some photos and most of them were spectacular. And some of them made left turns. And the guy who called himself out on it says, hey, for you junior residents and students, and this is what happened and and I won't do this again. So that was refreshing. And then the other cool thing that happened was Saturday afternoon when there was no conference. And what I mean by that is a guy by the name of Dr. Rosenfeld, who was my professor up at UCSF, and we've remained friends and we're close. And I bounce cases to his chagrin all the time. If I'll say, hey, am I thinking straight? I'm going to do X to Y to Z. And he's like, yeah, but do this instead. Oh, okay. And we're very similar in mindset. Again, I try to emulate him because he's such a good surgeon and good person. And he's out there and he's on a mission also for truth in plastic surgery as well and all that. So we're there and he's chairing the aesthetic surgery portion of it. And so it ends at noon. He's like, okay, so what are you doing this afternoon? I said, well, I don't have any plans. Like, fantastic. Great. So let me go ahead and call my wife and we're going to go down and we're going to get some sandwiches. And we're like, oh, okay. So that's exactly what happened it calls his lovely wife, Gina. And he says, do you have a car here? No. Perfect. So we go ahead and we're done. And he says, get in. So I go ahead and I get in his car and it was one of those perfect California days. It was about 80 degrees. He had the top down. Of course he did.
Nice.
And so he's got a house on the peninsula which is just south of San Francisco.
Yeah, it's so beautiful.
And it was just a really perfect day. And so we picked up some food and we went over to his house and we just kind of caught up. So you do really sometimes make lifelong friends or mentors. And we talked about everything. We talked about family. We talked about raising kids. We talked about blepharoplasty. We talked about facelifts. We talked about ethic. We talked about all of that stuff. And so that to me was really, really a cool thing as well.
Yeah. And having that, I mean, not only professional camaraderie, but just those friendships.
Right.
I mean, and also you're an alumni of UCSF, so you have all those connections and friends, and
right. So
that's an awesome thing.
And I asked him about a few things. I'm like, okay, I have this question. Who do I talk to? Oh, well, you need to talk to who is the, worldwide leader in X, and I'll send an introduction email. Oh, okay, fabulous, right? So it's so that sort of thing. And then that night was the residence dinner, which was it was cool. Again, I had one 22 years ago, and how that happened. But it's interesting to see another really spectacular group of individuals doing the plastic surgery thing. And we know that they're well-trained. They know they're going to go ahead and do good things. And then my chief was Dr. Mathias, who, we're broadcasting from my office. And if you look on the bookshelf behind me, half the books there have his name on it. And he passed away with ALS. And Dr. Hoffmann was given the reins, and Dr. Hoffmann is a spectacular plastic surgeon. I mean, he's the guy, and he's been doing this now for 40 years. Wow. We would get this consult from, pick a specialty, and we would go in there and see it, and he would be like, oh, okay, well, you just move this and put that there and flap that, and you'll be fine. And he would do it. We would pull it off, and you're just like, oh my God, and he just is spectacular plastic surgeon.
Like a wizard.
Yeah, I mean, just the vision. He's done it for so long, and 100%, which is also kind of interesting because, well, for example, and this happens to everybody, right? And again, the UCSF guys are spectaculars, right? But we get the phone call about 8:00 at night. We'll pick on the cardiothoracic guys, and the cardiothoracic guys will call and go, "Hey, you guys still here? Yeah. Could you kind of come by room 12? Yeah." And so sure enough, again, they got sent this like ridiculous big tumor. So they kept going back in the tumor and they finally cleared the margins, but boy, did they leave a big hole.
All right. Now what?
And so now they're like, I don't think we're going to get this together. So call the plastic folks. And so we go in there and go, oh, okay. And so like, I'm looking at the rib cage, I'm looking at the lung going back and forth. I'm like, that's not supposed to be there like that. And again, and you're like, okay, I'm thinking X, Y, and Z. And then Dr. Hoffmann comes in and goes, oh yeah. So do, X, Y, Z, put this there, put that there. Okay, great. So we do all that. And then, but the funny part of all that, and everything goes well, thank God. And so most of the time. And so the next day is kind of weird because they're in the ICU and then they finally get the tube out and all that stuff. And you're talking to them like, hi, I'm your surgeon. You haven't met me yet, but, basically you had a big hole in your chest and move things around and we fixed that. And, oh, well, okay. I'm glad you were around.
Right. Yeah, so, exactly.
So he actually has been chief now for 20 years. And so he at this thing says, yeah, well, I'm going to retire as chief. And we all went, what? So now they're down there. They've had, lots and lots of people who would want that job. And so he said, okay, well, it's down to about 6. And so now they're trying to figure out who's going to be the next chief of UCSF Plastic Surgery. And I'm thrilled that Dr. Hoffmann is still going to be around and still do surgery, but just not have to do the day-to-day chief
grind, right?
Stuff, right? Which is like all HR, but it's not just that; it's also research and it's a lot.
Right.
It's a lot, especially there because that place demands.
Because there's a lot of administrative besides just the
So God bless them. That's a tough. Being chairman or chief or something like that. That's a tough job, especially nowadays. Because things are, so money oriented. It's not just publishing papers or being clinically active and taking care of patients and teaching the residents. There's a whole lot of other stuff nowadays that goes along with it. And it's still terrific. And you're still working with patients and students and residents, but it's a lot. And so we'll see who comes up into that slot. So it'll be interesting to see.
Well, it's exciting, and it's great that you get a chance to meet your colleagues that you've known for several decades, some of them, and it's an amazing experience, I'm sure. Let's tell the folks how they can find us and social media and all that stuff. We have all that stuff.
Yeah, so we're all over the place.
We have all of it.
We have all of it. All the things, as the young ones say nowadays. So the keystone for us is the web page, which is www.jjrothmd.com. That's JJROTHMD.com. And then we are all over social media as well, from Instagram to YouTube to Facebook to all of it. And the podcast you're obviously listening to. And we actually answer the phone. And so if there's ever a question or a concern or any of that kind of stuff, call or reach out to us via the DMs. Does that slide into the DMs? Is that what they're saying now?
That's what all the kids do.
So kids slide in the DMs now. Anyhow, so and we actually do look at those and we do respond to them, and then we do incorporate them in our podcast or other thing or blogs and all that. So if there's something, if you have a question, Dr. Google's not your friend, okay? But ask us, and we're happy to do that. And I say that in the rooms all the time. I'd rather you spend 20 minutes with me than 20 hours on the internet, right? So, but by all means, if there's a question or anything that you want to hear about, let us know, and we'll get that on for you.
Awesome. And please like and subscribe to our podcast and leave comments. And we love comments. And if you have questions, for sure, DM us, as Dr. Roth said.
There you go.
And we will try to answer those if we can. Thank you so much, and have a great day.
Have a great day.
Thank you so much for joining us. For further information, please visit the podcast website link for Dr. Jeffrey Roth. See you next time.